isn't the same. Okay, so he is trying to revolutionize retirement and, well, seniors long-term care in Philippines. He spent the past 7 years with the European Chamber of Commerce promoting Philippines as a retirement and healthcare destination, and now he's focusing on Filipino long-term care. So please welcome Marc to the stage.
I'm going to tell you about why nursing homes are important and why they are a benefit to the community. I also want to tell you from my own experiences the struggles we have been facing. Maybe that's also a reason why I lost a lot of weight. And then I'm going to talk about the care model, which is a model of safe, actualizing care. What's important for you to know, one of the reasons why I'm here in elderly care now is this lady. It's my Lola. Her name is Helmine. She's 87 years old and she's living in Germany, make a guess, in a nursing home. She's been living there for the last 15 years and she loves it. I know the perception of nursing homes here, but I hope I can give you an idea about what an ideal surrounding can look like. She loves it because of community. So she has friends with whom she can play cards, board games, social activities. She can just go to the neighbor room and talk. She loves it because of the lifestyle that they are offering and of the readily available health care. My Lola, she had a stroke last year in July, and basically the active part of her disappeared. So she forgets names, she forgets that she has children, she forgets that she has grandchildren, and she's not active anymore. So what happened when we found out, I was in Germany, we brought her to a nursing home. They found out that same day that she had a stroke, and she was treated 4 days in the nursing home, and after the 4 days 4 days in the hospital, and after the 4 days she was brought back to the nursing home. And I basically want to show you what happens if it's the Philippines surrounding, what's the usual process. So we basically have the home, and then you have an acute medical incident happening. Then you are brought to the hospital, and usually the hospitalization here takes quite longer because there is no other place where you can go except you go back to your home or you go back to, the cemetery. And we are looking at models which are used in developed countries. And the Philippines is not only a developing country, but it is already a developed country looking at different regions. And we feel that there should be different models available. So you have the home, you have the hospital, and then let's just use RainTree for now, but it can be any other provider. You have a long-term care provider, nursing home or home care. So what makes the difference now? You go to the hospital, and from the hospital you can be brought back home, but it can be a transitional care model. So the nursing home provider helps you in your home to adjust again. How? Home care. So you go back home, but let's say your parents go back home. And what would you usually do? Most probably you would take 1 or 2 weeks off because there is no one who can professionally manage it. So the home care takes part of this. They send a professional case manager and take care of your beloved one. Another option is the daycare. So you're working 8 to 10 hours a day. Now with the increasing traffic, you're out for 14 hours a day. Who looks after your mom? You can bring her in the morning into a long-term care facility and fetch her again in the evenings. It's day care, so she's not alone at home. She has people that are looking after her. Then the other possible model is, and I know that this is socially a difficult topic in the Philippines, your mom goes for long-term care to a nursing home. What are potential areas where this is happening is there is no way you can look at your mom at home anymore. She has Alzheimer's, dementia, she runs away, she's unhappy, you have conflicts at home. you are not living in the Philippines, or we have a lot of OFWs coming back looking for this kind of services. On the other hand, nursing home is not the hospital. So for acute care, you go back to the hospital, and from the hospital, you can go back for long-term care again to a nursing home provider. Basically giving you the chance to stay in a home-like surrounding and not in a hospital surrounding. I want to talk a little bit about the care model. The care model that we are using and which is widely used worldwide was developed initially in Germany by a lady called Marc Daubenbuechel, and she developed it for people who have a stroke. If you have a stroke, usually you lose certain abilities. What you do then is, with this care model, you want to limit the dependency. You want to bring the patient slowly back to normal state. You want to give them self-esteem with the resources that they still have. What happened later on, the model, or pretty fast, it was adopted by the geriatric care industry in saying, how can we ensure that we take the maximum of the resources that the patients still have. And this is a model of the safe actualizing care. How, and I was thinking, how can I describe it in 3 to 4 minutes to cover the other topics? And I love using this picture. It explains the model of safe actualizing care, and do me a favor, look at the hands. If you look at the hands, you will see that they are in the pocket. And I'll explain to you after 3 points why. In the model of safe actualizing care, you observe the patient. You look what are the resources. You basically do this through a check. And then you let the resident implement it. And we call this, and you only get involved only if needed. And we call this the work with your hands in your pocket. But this is not easy. It's actually difficult, it's more time consuming, and you take a lot of responsibility, and I'll explain you why. When you assess a patient, it's a time consuming progress. We have 2 of my nurses here, they know it. I want to show you, this is an assessment which takes about 1 week. In looking what are the different areas that the patient can still do. How do you do that? We talk with the resident or the family and discuss it jointly. Sometimes if the resident can't anymore, that's then the time where we talk to the family. And then we say, what is the appropriate level of assistance? Is this observance, guidance, support, partial takeover, or complete takeover? And this is what's the time consuming. If you would take a complete takeover for somebody who cannot wash his hair anymore, it would be faster. But we try to let the resident wash the head by himself. Or we give guidance, or we do a partial takeover. So they feel they can still do things by themselves. You also define a care goal. So you maintain, you rehabilitate. It depends on the resident. You find this out when you do the assessment. And the assessment is not done by a doctor. It's done by the head nurse, and then jointly the medical steps are discussed with the doctor. What's important is we should not over-challenge nor under-challenge the resident. It needs to be realistic, and we need to adapt to his way of doing things. We are there for the resident to get him back or maintain his state, and it's not about that we dominate the resident. This, just very briefly, I showed you this long care assessment, and basically we look at 12 daily activities of life. And these are, I need to read it, I always forget it as well. It's a communication ability, and if you have questions, I don't go into detail, ask me later on. It's the ability to move, ability to keep the vital functions up, ability to take care of himself or herself, sorry, ability to eat and drink by himself, ability to excrete, the ability to dress, ability to rest and sleep, ability to entertain himself, ability to feel as men or as women, ability to care for security, and the ability to handle existential experiences of daily life. Especially the last one is very important, because we need to, when persons have Alzheimer, they go back into their early childhood. And this experience becomes so important. In Europe, it's especially the World War II. And we need to understand what threatens people, what makes them feel uncomfortable. So this is a very long part. So how does it go together? You can't basically do safe actualizing care without preventive medicine. It's actually a part of it. If you look at the stroke patient, it's always interlinked. It goes down to the food. It goes down to the exercise. That's why the registered nurse always needs to work closely with the physician. A nursing home doesn't employ physicians, but it can also not work without physicians. Our team will give to each one of you one of these roses, and I would like to ask you to bring it home and look at the rose while it's fading away over the next week, and think, how do I later on want to be, I think I look like later like I'm proposing to someone, but how do I want to be looked after later on? How do I want my parents to be looked after later on? How do we want to care for them with dignity? What are the models that are basically available? Would we use this kind of models? Additionally, we will hand out a letter to you, which you can sign or you don't sign it. It's a letter to the Commissioner of the Housing and Land Use Regulatory Board, because he's the only one who can make a difference. He's the only one who can basically say, yes, we support this kind of projects. Or see, there's still more roses coming. I would like to, it's okay. I would like to thank you for your attention. I've been 4 or 5 minutes over my time, so thanks a lot, Richard, for giving me this time. And we'll distribute the roses to you, and I will also approach you during lunch and ask you what your thoughts are, because I'm very happy to learn from all of you. Thanks.